Good day, my name is Imelda Williams. This presentation will focus on abnormal radiographic appearances of the pelvic girdle and the lower limb, and this is part C of the series and the final part. Part C will focus on the ankle and the foot. I trust that you've reviewed both part A and part B before attempting part C. The referral rules for radiography, there's international rules called the Ottawa ankle rules, and these rules indicate when an x-ray of the ankle is clinically indicated. And it's clinically indicated if the patient is unable to weight bear, or when there is tenderness at the tip or distal 6 centimeters of the posterior aspect of either of the malleoli. So for adequacy of the ankle, a mortise view and a lateral view is the standard views, and it's important to be able to visualize the soft tissue. On the AP view, the distal tibia and fibula should form the mortise around the talar dome, and on the lateral view, the malleoli should overlap, and the base of the fifth metatarsal should be included. Checking for alignment, the uniform joint spaces in the tibio-talar and talofibular joints should align, and the fibula should overlap the talar dome on the lateral view. And for the bone, check the distal fibula for any avulsions, and then check all of the bones for the cortical outlines to see whether there's any steps in the cortex. So view carefully the tibia, the fibula, and the talus. The joint spaces should be uniform, and then in terms of the soft tissue around the malleoli, check if there's any avulsion fractures within the soft tissue, or if there's a displaced fat pad at the anterior joint line of the lateral view. And I've given again radiographic views, and this is the aping of the ankle mortise, and then the lateral ankle view, and I will give feedback on that when I give feedback on the practice plan. Horizontal fractures at the ankle joint are distal to it. The mechanism of injury for that is inversion injury, and that is quite common. And then spiral fractures at the distal tibio-fibular joint are distal to it. Mechanism of injury is commonly eversion injury. And then you could also have fractures between the inferior tibio-fibular joint and the head of the fibula due to the fact that the tibia and fibula forms a ring-like structure with the ankle and the knee joint. And on this image, there's an avulsion fracture due to inversion injury and with the pull of the calcaneofibular ligament. Here we've got an example of an eversion injury, and you can see that both the malleoli has been fractured, but then also there's the posterior malleola that has also been fractured, and that is visible on the lateral view. And then there's displacement of the ankle joint. There's two typical classifications used for ankle fractures, and the first one I'm going to discuss is the Janus-Weber classification. It uses the position of the level of the fibular fracture with its relationship to its height at the ankle joint. And the type A Janus-Weber classification, the fracture sits below the ankle joint. At type B, the fracture is at the level of the joint with the tibiofibular ligaments usually intact. And type C, the fracture is above the ankle joint, which tears the syndesmotic ligaments, and the ligaments, because of that, there is some dislocation at the ankle joint. When you look at these images, the image on the left shows a typical type A Weber with a fracture below the ankle joint. The middle one is a type B with a fracture at the level of the ankle joint. And then the one on the right is a type C with a fracture above the ankle joint. In addition, there's the POTS fracture classification, of which there's also 3 types of POTS. 1 is a spiral fracture of the lateral malleolar. Type 2 includes a spiral fracture and avulsion fracture of the medial collateral ligament plus an avulsion of the medial malleoli. And then type 3 is all of the above, and in addition a fracture of the posterior malleolus with anterior dislocation of the tibia. And here's a bimalleolar fracture of the POTS, or POTS fracture, and this occurs as a result of disruption of the tibiofibular syndesmosis. In this image on the AP view, we can clearly see that the lateral and the medial malleolia has fractures, but on the lateral view, the posterior malleolus also has a fracture, and this is a trimalleolar fracture. The talar tilt can be measured by inversion stress views, and on the stress views, an angle is formed by the line drawn along the tibial profonde as well as the dome of the talus, and that tilt, a tilt of 15 to 25 degrees indicates a ligamentous injury. It's useful to do a comparison of the contralateral ankle. If the degree is greater than 25, then that is always abnormal. Talar neck fractures. So talar fractures are the second most common fractures of the tarsal bones. They may involve the head, the neck, or the body, or the posterior process. And then there is a Hawkins classification, which is based on damage to the blood supply of the talus. And this serves as a guide to the healing process, whether there's a possibility of osteonecrosis, and assist in making a decision whether an open reduction is indicated. So the type 1 of the Hawkins classification is an undisplaced fracture of the talus. Type 2 is where the fracture is displaced, and type 3 is where it's displaced the body of the talus, and this is then locked behind the system-taculum tali and results in rotation. Neck of talus fractures creates complications, which includes non-union avascular necrosis. Osteochondral fractures can be very subtle, so look for small flakes of bone or defects in the cortex of the talar dome, as can be seen in the image on the right. A Tilot fracture is a vertical fracture line with extension from the distal articular surface. The juvenile Tilot fracture is a fracture through the epiphyseal plate and is typically a Salter-Harris type 3 fracture. And the usual age for that is between 12 and 14, with the mechanism extreme eversion and lateral rotation of the ankle. On these images, we can see the plain X-ray on the left, and then also see how valuable a CT scan would be to determine that this is a Salter-Harris type 3 fracture, where the fracture is lower than the epiphyseal line. Calcaneal injuries usually result from a fall from a height. It's also associated with T12L1 compression fractures. Most fractures are visible on the lateral projection. However, they can sometimes be subtle, so look for the cortical disruption, any evidence of a sclerotic line, and then check bolus line, which should be between 20 to 40 degrees. This bolus line, the angles differs from textbook to textbook, but this is the most common accepted degrees. So the bolus angle is drawn by drawing a line from the posterior superior margin of the calcaneus to the tip of the posterior facet of the subtalar joint, as can be seen on the image on the left. And then the second line is drawn from the tip of the posterior facet of the subtalar joint through the superior margin of the anterior process. And you can see the image on the right that degree is much less than 20, and that indicates that there is a compressed calcaneus fracture. The angle of Gissane is also known as a critical angle, and is formed by the downward and upward slope of the calcaneal dorsal surface, as indicated in the image on the right. The normal degree should be between 125 to 140 degrees. If it's greater than 140, it suggests a fracture of the posterior facet of the subtalar joint. Now there's a fat pad which sits just in front of the Achilles tendon, and that's called the Cagus fat pad. That fat pad is an indication of swelling in the area, but it's not similar as with our other fat pads that would indicate that there should be a fracture. The Achilles tendon tear, the lateral ankle view with a soft tissue technique, so a very low KB, is very useful to demonstrate Achilles tendon, but MRI and ultrasound is much more sensitive to identify and confirm an Achilles tendon tear. The image shows on the right that there is a lack of definition of the Achilles tendon. There's a lumpy soft tissue mass which is closer to the arrow, and then there's faint calcifications within the injured calcification, and that you can see on the open arrow, the larger open arrow. It's important to differentiate between normal variants versus fractures, and in particular when we have images where there's accessory ossicles. Avulsion fractures have sharp margins, they're not well corticated, and they should fit like a jigsaw puzzle into the adjacent bone. So look for signs of a small lucency in the adjacent bone. Whereas ossicles are well rounded with well corticated margins, and there's numerous accessory ossicles around the foot and the ankle. And here I've included a slide from Greenspan and Belton, which shows the numerous accessory ossicles in the ankle and the foot. There's an example of an accessory navicular ossicle. You can see that where the arrow is. And then one of the most common ones is the os trigonum, which can simulate an avulsion fracture at the posterior process of the talus. And the os peroneum, the sesamoid, this is a sesamoid which lies within the tendon of the peroneus brevis, and it is situated next to the cuboid. And then the calcaneal spur is also quite common. Now moving on to the Ottawa foot rules. A foot x-ray is required if there's pain in the midfoot zone, and then if there's bony tenderness at the base of the fifth metatarsal or at the navicular, and when the patient is unable to wait there. Some of the causes of a foot injury. Talar injuries, the mechanism of injuries falls onto the fetal violent ankle dorsiflexion, such as in a road traffic accident. Calcaneal fractures fall from a height onto the heels of the foot. And then the upper and midfoot dislocations is violent twisting injuries. Metatarsal fractures and dislocation is direct trauma when an object falls onto the foot, or crushing injuries. Avulsion fractures at the base of the fifth metatarsal, and that's inversion injuries of the foot. And then finally, stress fractures of the metatarsals is due to prolonged exercise. I've given here again an oblique foot, so try and identify the labels as well as on the lateral of the foot. There's a number of joints in the foot. We've got the hindfoot midfoot joint, and that is the transverse tarsal joint, which is Chopin's joint. Then there's the midfoot forefoot joint, which is the tarsometatarsal joint, and that's called the Lisfranc joint. And then we also have the talus and the calcaneum, and that is the subtalar joint, and that's in addition to the interphalangeal joints, the metatarsophalangeal joints. And then here's an image of a foot x-ray which indicates all of these joints. Sesamoid bones are normal variants. They are small bones which sit within tendons where the tendon is exposed to friction. These sesamoid bones can be either bi, tri, or multipartite. They can also be unilateral or bilateral. So they could have a variable presentation, and it may be difficult to distinguish sesamoid bones from a fracture. We've spoken about stress fractures. Normally it affects only one metatarsal, and it tends to, in the foot, affect either the second or the third metatarsal. And the early signs is when you see a fine incomplete fracture line with a fluffy callus formation. And then in the next foot, we have a march fracture, which was missed, and you can now see on the second metatarsal near the head that there is fragmentation of the bone due to this missed stress fracture. The base of the fifth metatarsal, avulsion fractures are most common at this site due to an inversion injury. It occurs at the most proximal tip of the fifth metatarsal where the peroneus brevis tendon attaches. The fracture normally, the appearance of the line, the fracture line is either transverse or oblique, but never vertical. A Jones fracture is a fracture of the base of the fifth metatarsal but further along, and it occurs about 2 centimeters distal to the metatarsal base. And this is caused by a twisting inversion injury, so not due to peroneus brevis avulsion. This is quite common in ballet dancers. So this is due to the poor blood supply to this area. Quite often there is delayed union. Now, patients might have an unfused apophysis at the base of the fifth, which could be confusing, especially if there's an inversion injury. With an unfused apophysis, the lucent line is more lengthwise, and with a fracture, it's usually transverse. On this image, it shows a fractured metatarsal shaft with Lisfranc fracture dislocation. Here we have assessment of the images. And on the DP radiograph, the medial margin of the base of the second metatarsal must align with the medial margin of the middle cuneiform, as indicated with the black line. On the oblique projection, the medial margin of the third metatarsal should align with the medial margin of the lateral cuneiform. There's 2 types of Lisfranc fracture dislocations. So the associated fractures are at the base of the second metatarsal, most commonly. Also the third metatarsal, the first or second cuneiform, as well as the navicular bone. When the dislocation is laterally for both the first to the fifth metatarsal, this is known as a homolateral Lisfranc fracture dislocation. However, if only the second to fifth metatarsal has dislocated laterally and the first metatarsal is dorsally dislocated, this is then known as a divergent Lisfranc fracture dislocation. So in this image, we can see this disruption at the Lisfranc joint or the distal tarsus and metatarsus. There's severely comminuted Lisfranc fracture dislocations, And if we look very carefully in the soft tissue, we can see that this is also a compound fracture, and we can see the surgical emphysema, so abnormal air within the soft tissue. This is also a divergent Lisfranc fracture dislocation. Some other midfoot injuries, fractures of the cuboid, navicular, and cuneiforms must be searched for. These are rare and usually result from severe trauma, so it's important that you examine the images carefully. So if we look on this image, we can see, if we look at the cuboid, we can see that there is a fracture of the cuboid bone, and it also looks as if there is a suspicion of a fracture of the navicular as well. Phalanx fractures are common, and normally it's with direct objects falling onto the foot. And here's an example of a crush fracture. And then also a dislocation of the proximal of the metatarsophalangeal joint. Pediatric fractures, very typically there's the toddler's fracture, so it's at the age when the toddler starts to walk, and this it can be seen as a very subtle spiral line. Triplane fractures are complex fractures. They can be very subtle. Normally on the AP view it shows a vertical fracture of the epiphyses. However, CT is very good to demonstrate that the fracture runs through the sagittal coronal as well as the axial plane. Non-accidental injuries. These fractures considered pathognomonic of NAI, and it's the bucket handle or metatarsal when the infant is shaken and the limbs are left to flap. Fractures can also be seen at different stages of healing without an adequate explanation for these fractures occurring. If NAI is suspected, a full skeletal survey must be done, and as well as a bone scan to exclude any further subtle fractures. So the main message is that you need to apply your ABC search strategy when you interpret radiographs of the pelvis and the lower limb, so that you can distinguish the normal from the abnormal. And then remember to apply alignment principles to identify any dislocations or fractures of the pelvis, and for example, as we just discussed, in the foot, and then identify any soft tissue signs, especially lipohematrosis, which could indicate the presence of an occult fracture. So it's important that you know the appearance of common fractures, the appearance of common pathologies, and then to be able to differentiate between intracapsular versus extracapsular fractures of the hip. And then don't forget about the importance of apophyses in the unfused pelvis, which needs to be appreciated to distinguish possible avulsion fractures. And then finally, if you deal with a pediatric patient, apply the epiphyseal fracture classification, so your Salter-Harris classification when there's fractures near the joints of pediatric patients. Thank you.